Welcome back to Crush Medical. We've got a high-yield pediatric cardiology question that students absolutely get stumped over all the time. So looking forward to breaking this down. Make sure to like and subscribe, help the channel grow so we can continue putting out more free content. That's going to ultimately benefit you guys, okay? Check us out at crushmedical.com. We've got quite a few services, a premium bundle flagship service where we include examination, coaching, mentorship, and putting together your entire CaRMS and MyERAS application so you match on your first attempt. We do that, okay? We provide all these services as well as a free MCCQE1 study guide and a high-yield Anki deck, which is one of our best sellers. Check us out, okay? Let's jump right into this question. So we have a term neonate who is cyanotic in the delivery room with normal heart sounds and no murmur. Room air ABG, so ABG is also known as arterial blood gas, so pH 7.38, okay? PCO is 32, PO is 78. After 10 minutes on 100% oxygen, pH is the same, PCO slightly went up, and PO went up significantly to 107, right? What is the most likely cause of this cyanosis? So let's just quickly take a step back here and unpack some of the high-yield findings and kind of go through this in a stepwise fashion. So first thing is this neonatus term, right? So it's not a premature, it's not some early delivery. This was on term, okay? So that's the first important thing. And they are cyanotic in the delivery room, okay? So cyanotic just essentially means that they're not oxygenating well, and therefore they, on physical appearance, they're going to appear blue. They're going to appear like they're gasping for air and just not oxygenating well. Physically, you can see this, okay? In the delivery room with normal heart sounds, that's important, okay? And no murmur. So again, these are kind of, they're establishing baseline findings here. The real ABG scenario, what they're telling us is that after 10 minutes, they gave this neonate 100% oxygen, and their partial oxygen pressure actually went up, right? So that is important because they're essentially telling us this is not a lung pathology, right? The oxygen, once they administer oxygen, and you see that rise in PO2, we can say that the lungs are actually ventilating, like they're doing their job. They're just not getting enough for some reason, right? So that's the first bullet. And more importantly, let's say they gave 100% oxygen and you don't notice an increase in PO2. Now we can say there's some underlying lung pathology. Maybe it's atelectasis, maybe it's just improper development, or the lungs are full of fluid, but they're just not oxygenating, which is what is going on here, right? The fact that they tell us that this patient's PO2 went up after 10 minutes of 100% oxygen tells us that this is not a lung pathology, but in fact a heart issue. Okay? So now that we've established that groundwork, let's go through the options one by one. So what is the most likely cause of this cyanosis? Coarctation of the aorta, very high yield diagnosis. In this case, it would be incorrect here, right? And what is coarctation? Well, firstly, how it typically presents is it causes something called differential cyanosis, right? Where the upper limb is actually hyperperfused, so it would appear well, strong pulses, pink in appearance, but the lower half, the lower limbs would actually be hypoperfused. So it would appear blue and just not, you would have poor skin turgor, and appearance-wise it would just look cyanotic. So you can quickly physically see that the upper half is oxygenating well, the lower half isn't. And that is how textbook coarctation of the aorta would present on board examinations, okay? Outside of that, it actually presents often with a murmur too. So in this case, that's just not what is going on here, right? So that is concerning here, and this is just not the option here. Coarctation of the aorta, incorrect here, okay? Transposition of the great vessel. So this is a very interesting diagnosis, and that is in fact the correct answer here, okay? Very high yield, and this is important for pediatric cardiology as to what is actually tested, right? They love this question. So profound cyanosis at birth, they present with normal heart sounds and no murmur. And again, the more important thing is a failed hyperoxia test. So PO2 barely rises on 100% oxygen is classic for TGA, right? So in this case, parallel circulation, systemic and pulmonary loops, they run completely separate and blood doesn't mix. So that's the problem here, right? The problem is that because um, the transposition, they haven't completely developed to the point that perfused blood is coming back into the heart from the lungs. That's why these patients are experiencing this sense of cyanosis and hyperoxia, right? So again, failed hyperoxia test, PO2 78 to 107, only lung disease would actually rise far higher. So that's something to be aware of, okay? No murmur, cyanosis from a fixed right to left shunt, not turbulent flow. Okay, so a cyanotic newborn whose PO fails to rise on 100% oxygen has cyanotic heart disease, right? Congestive heart disease with right to left shunting with no murmur, think to transposition of the great vessels, okay? So this is a very difficult concept. At the same time, once you actually go through the other options, we can see why this would be correct, okay? So let's come back. VSD. So again, what do we know about VSD? It presents with a holosystolic murmur. Very common, right? You can actually present this, and generally this would need to be addressed, right? So let's see. VSD is a left to right shunt. It's acyanotic early on, but as they get older, they present with symptoms. In this case, there's no murmur, and the child is cyanotic, so this just doesn't fit the clinical picture, okay? Incorrect. Then we have patent ductus arteriosus, also known as PDA, everyone's favorite, the machine-like murmur. This would be incorrect here. Left to right shunt with a continuous murmur. These patients are not cyanotic, right? Again, this baby is cyanotic. This textbook, they don't present this way. So PDA, VSD, and ASD, they actually are all acyanotic until later on. So when they're actually born, they appear healthy. Just be aware of that, okay? So PDA is incorrect, and of course I just mentioned ASD, atrial septal defect. Now we have a left to right shunt, usually silent in newborn with no early cyanosis. So ASD, PDA, VSD right off the bat, because they don't appear cyanotic at birth, they're automatically ruled out. That really just leaves us with coarctation and transposition of the vessels. And if you recall, I quickly mentioned coarctation physically. You can see that they appear upper half is well perfused, appears pink, and appear skin color as well as skin turgor, like you can feel that perfusion, whereas lower extremities hypoperfused and it appears cyanotic. So we can rule that one out as well. That leaves us with transposition, right? And again, something that we mentioned was that the hyperoxia test, only lung disease would actually rise higher than this, so just be aware of that, okay? And if you enjoyed this question, make sure to like and subscribe, and we'll see you in the next one.